Acute otitis externa is an infection or inflammation of the external ear canal. Commonly known as swimmer's ear, it occurs in temperate climates, peaking in the summer when swimming and prolonged water exposure occur frequently. The condition is more frequent in teenagers and young adults and in those who use indoor heated pools. Hi, I'm Dr. Zoran Becvarovski. This talk briefly summarises the clinical presentation of otitis externa and the available treatment options. The most common cause of otitis externa is bacterial infection, of which the most common pathogens are Staphylococcus aureus and Pseudomonas aeruginosa. These account for approximately 90% of all infections. Other causative agents, including fungi, account for the remaining 10%. Bacterial otitis externa presents as a painful, discharging ear. The ear is usually tender to touch, and the pain may worsen with movement of the head or pinna. The fluid draining from the ear is often yellow or yellow-green in colour and may be foul-smelling. Patients often complain that the ear feels blocked or is itchy. There may be an associated hearing loss and or tinnitus. In severe cases, the patient may become quite toxic and unwell. In rare cases, otitis externa may lead to skull-based osteomyelitis, resulting in facial nerve paralysis, central nervous system toxicity and even death. This may occur in elderly, immunocompromised or diabetic patients. A careful history and examination are needed to distinguish otitis externa from acute suppurative otitis media. In otitis externa, the ear canal is quite red and swollen, becoming narrower and making it difficult to visualize the tympanic membrane. It is preferable not to syringe a discharging ear. Rather, a cotton tip applicator or suction may be used to clean the debris. Hearing should be assessed as part of the clinical examination, preferably with a tuning fork. Examination of the pre- and post-auricular regions helps distinguish between otitis externa and acute suppurative otitis media with or without mastocytitis. In both cases, the discharge will fill the ear canal. However, in otitis externa, the ear canal is narrowed and the pinna is exquisitely tender to even the most gentle manipulation. The tender area tends to be in the preauricular region due to infected parotidine lymph glands. In contrast, in acute suppurative otitis media, the ear canal is not usually edematous, and if there is mastocytitis, the tenderness is worse in the post-auricular region. By definition, these patients have a perforated eardrum. That is, the infected middle ear fluid discharges into the ear canal. This similarity between the two conditions makes the diagnosis and choice of antibiotic treatment extremely important. Some antibiotics have been associated with ototoxicity when the eardrum is ruptured. This is a potential problem when it is not known whether the eardrum is perforated or not. Treating bacterial otitis externa requires a combination of careful cleaning and medicated ear drops. Topical antibiotic therapies are an efficient strategy because they deliver significantly higher concentrations of the antibiotic to the infected area compared with the systemic route. The most commonly used ear drops contain either an aminoglycoside or a fluoroquinolone. After decades of monitoring, there is minimal evidence to suggest that the observed increase in resistant microorganisms can be attributed to topical antibiotic therapy. There is a potential for side effects with any broad-spectrum antibiotic, but compared with systemic therapy, use of a topical antibiotic reduces the risk of adverse effects such as diarrhea, vomiting, and skin rashes. The addition of a steroid in the eardrop helps reduce swelling and pain. Both aminoglycosides and fluoroquinolones are effective in bacterial otitis externa and are associated with low rates of intrinsic resistance. Fluoroquinolones such as ciprofloxacin have a broad spectrum of activity and are particularly effective against Pseudomonas aeruginosa and Staph aureus. To date, there is no documented evidence that fluoroquinolones are associated with ototoxicity or balance disorders. These conditions have been associated, albeit rarely, with other topical antibiotics where the tympanic membrane is not intact. The American Academy of Otolaryngology Head and Neck Surgery recently released a consensus panel report cautioning against the use of ototoxic antibiotics in the presence of a non-intact tympanic membrane. In addition, during my fellowship at the Michigan Ear Institute, we developed and used the human labyrinthine sampling model to show that when ciprofloxacin is instilled into the middle ear, there is no measurable absorption into the inner ear, serum or cerebrospinal fluid. In contrast, when gentamicin was administered into the human middle ear, we found that within 5 minutes there was measurable inner ear absorption of the antibiotic. Sensitization is a relatively common feature with aminoglycoside treatment. One study found that approximately 1/3 of patients develop allergic responses to aminoglycosides such as neomycin. In contrast, sensitization is rare with ciprofloxacin. Recent studies have shown the benefit of adding a corticosteroid, that is, hydrocortisone plus ciprofloxacin compared with ciprofloxacin alone, results in less inflammation and pain. Ciprofloxacin HC is the only ototopical fluoroquinolone approved for use in acute bacterial otitis externa in Australia. It combines the antibiotic efficacy of ciprofloxacin with the anti-inflammatory agent hydrocortisone and is approved for use in patients 2 years and older. Adverse effects are relatively uncommon, although a white or off-white excipient plug may form, which, if unsightly, may be removed. The dose of ciprofloxacin HC is 3 drops twice daily for 1 week. Ciprofloxacin HC is available on the PBS for EPAT patients and as a private script for the remainder. Regardless of the chosen therapy, it is crucial that the drops are used correctly. In the treatment of refractory cases, the problem may simply be incorrect delivery technique, as insufficient antibiotic is being delivered to the infected site. To overcome this problem, the ear should be pulled up and back during application, and the patient should lie on their side for at least 5 minutes following administration. The tragus should be gently pumped back and forth 5 to 10 times to ensure the drops penetrate into the deep parts of the infected ear canal. In resistant cases, or when the ear canal is closed, an otowick may need to be inserted to hold the eardrop in contact with the skin of the ear canal. This is usually a compressed sponge that absorbs the eardrops. These patients may also require administration of a systemic antibiotic. In more severe cases, hospital admission for intravenous antibiotic therapy may be required. The patient also needs to adhere to appropriate water precautions for 4 weeks from the onset of treatment. This consists of applying a cotton wool ball soaked in Vaseline to the outer ear during showering. Swimming should also be avoided. Remember to prescribe adequate analgesia, as this condition is quite painful. In summary, otitis externa is a common problem in temperate climates and can be treated effectively and safely in most cases by general practitioners with meticulous cleaning of the ear canal and the appropriate use of ototopical antibiotic therapy.